Thank you very much, Dr. Sumaya. Now I request Dr. Mazhry, he'll be talking on Pediatric IOL Exchange.
Bismillah ar-Rahman ar-Rahim. Pediatric IOL Exchange is the topic. Why do we need Pediatric IOL Exchange? The only major reason is myopic shift, change in refraction. And pediatric eyes being too reactive may give rise to other reasons as well, like subluxation, dislocation. Sometimes the phimosis is too extensive, and you may need to change the lens. But myopic shift is a major reason. And why does this myopic shift occurs? What's the size of the pediatric eye at birth? 16 to 17 millimeters. And at 1 year? 20? And 2 years? And 20 years. So there is about 4 millimeters of growth during first 2 years, and only 1 millimeter of growth from 2 years to adulthood. So the younger the child is at the time of implantation, the more chances of myopic shift are there. So there are two schools of thought. One who implants IOL even at 6 months of age. And most of the pediatric surgeons agree at 1 year of age. Even if you implant at 1 year of age, even then there is myopic shift. And these eyes behave too differently. Even two eyes of the same child behave differently. One in growth. Generally, there is always an isometropia and always asymmetry in growth of these pediatric pseudophakic kids. So you need to be ready for that as well. And how should we correct then to get rid of this myopic shift? You undercorrect. If you undercorrect, you lose the advantage of IOL, because you will be giving the child at 6 months of age about plus 10 diopter of hyperopia. That's equal to an aphakic correction. And hyperopic amblyopia and hyperopic correction, and not using it and not getting it fixed every 6 months will give rise to amblyopia. As compared to if we correct the child near to emetropia by 1 year of age, then the child will get myopic. And we know the myopic kids don't get amblyopic. Even myopic and isometropia doesn't matter for kids. One eye is -8, the other eye is -5. The chances are that the both of the eyes will be seeing because of their different near far points. So my tendency is to implant the IOL at any given stage and then wait for the myopia to occur, and when it reaches about by 10 to 12 years of age, you consider pediatric IOL exchange. So this was the background discussion. And this is a child. Of course, the picture is here with consent from his mother. We implanted at about 4 months of age. And the power was about 40 plus diopters. And we implanted about 30 diopters at that age. And he was about 6 plus 6 refraction after IOL implantation. And this is, he was implanted in 2011, and this video was recorded in 2015. And he was about -4 at that time in one eye and -6 in other eye. And he is enjoying video without any glasses because it lies in his far point. And that's the reason he did not get amblyopic. And this was his EUA at the same time. The video will not play, I think. And in 2023, when he was about 12 years of age and was -17 in one eye and -14 in other eye, we exercised a bilateral pediatric IOL exchange. 3.2 millimeter is the incision I performed to start. And you see this tilt of the knife inside. The incision is 3.2 millimeters outside and 3.5 millimeters inside. And then you dissect the IOL very carefully using visco cannula and Sinski's hook and T-dialer, and even sometimes you need a cystitome needle to free the iris from the cornea if the synechia are there, and the lens as gently as possible. And you keep on teasing and at the same time taking care not to exercise too much power. There may be a radiodialysis. And then you need sometimes to use scissors to cut the synechia down. And once you are able to dissect the intraocular lens from front adhesions and back adhesions, again the keratome goes in and same maneuver I perform rightwards and leftwards so that the internal lip of the incision is larger than the external one. And we are going to go for wound assisted folding. A scissor is being used to cut the inferior haptic because I was not able to free it. And once this freeing of the intraocular lens is there, McPherson's forceps is used to grab the lens right from the center after deepening the anterior chamber. And in a rotatory motion, you just hold it, grab it firmly, and you have corneal forceps in your other hand. And you fold it and rotate it through the wound outside. And I don't cut the lenses inside the eye to avoid trauma. And once the lens is out, the vitrectomy had been already performed. The standard procedure I perform in pediatric eyes is anterior axis, IA, posterior axis, anterior vitrectomy, and IOL implantation. So no other maneuver was needed. We implanted Acrisoft multi-piece IOL in the sulcus, and I applied a cross stitch on the wound. This is the other eye. The same procedure. The incision is being performed, and the wound will be a little enlarged. The situation is a little different. There is more fibrosis and synechia, but the visual axis is still clear. And we were able to successfully explant the IOL with wound-assisted folding and explantation, followed by Acrisoft multi-piece injection and placement in the sulcus. So postoperatively, it's all good as pediatric eyes. You need to take care of uveitis. We generally use these syrup steron because now the steroids are available in the syrup form as well for about 2 weeks, and orally steroids and other things. And the child behaved very well. His refraction, postoperative refraction is about plus 2.50 diopter. And the IOLs which we implanted were plus 13 in one eye and plus 9 in other eye. And the residual refraction is plus 2.5 diopters, which we did not aim. We aimed for emetropia. But again, the calculations are too difficult in pediatric patients, but this will go in his favor. By 20 years of age, hopefully he will be emetrope. And this is a story which I have repeated with 3-4 other kids. And thank you very much for your attention.